Welcome to 2-Minute Anaesthesia in Critical Care. Today let's discuss primary graft failure after cardiac transplant. This talk will mainly focus on primary graft dysfunction, which presents as severe ventricular dysfunction of the donor heart, which is unable to meet circulatory demands of the recipient in the immediate post-transplant period. It manifests as either left or right ventricular dysfunction or biventricular dysfunction, typically presenting with a low cardiac output, hypertensive state, despite adequate filling. There's no clear etiology. Conversely, there's also a secondary graft dysfunction where there is a clear etiology, i.e. pulmonary hypertension. How common is this? So there's 4,000 adult heart transplants annually. Primary graft dysfunction is a leading cause of 30-day mortality post-transplant and affects 10% of patients. The donor heart is exposed to a range of different physiological insults. These include brainstem death, hypothermic ischemia, warm ischemia, and ischemic reperfusion injury. In donation after brainstem death, DBD, rising intracranial pressure leads to brainstem herniation and pontine ischemia. This triggers an adrenergic response, causing systemic and pulmonary hypertension, increasing ventricular afterload and therefore risking myocardial ischemia. Baroreceptor stimulation may lead to a Cushing's response, i.e. hypertension and reflex bradycardia. Once the heart is removed and placed in cold storage, this induces hypothermic metabolic arrest, preserving organ viability by reducing cellular swelling and limiting reperfusion injury. In this low temperature, low oxygen state, the heart shifts from aerobic to anaerobic metabolism, leading to a gradual reduction in ATP, which over time can compromise the function of the organ. On arrival of the heart at the recipient centre, the heart is removed from cold storage. The interval from this point to the release of the recipient's aortic cross-clamp is termed the warm ischemic time. During this point, the temperature rises, increasing metabolic activity, promoting the generation of oxygen-free radicals. The next is the ischemic reperfusion injury. This refers to the cardiomyocyte damage caused by the restoration of blood flow to the myocardium. Upon release of the recipient's aortic cross-clamp, reperfusion of the donor heart leads to calcium overload and the generation of oxygen-free radicals. So what are the risk factors for primary graft dysfunction? They can be split up into donor, recipient and procedural. Donor risk factors include increasing age, female donor to male recipient gender mismatch, the etiology of the death, increase in LV hypertrophy due to the increased risk of ischemic injury, and increased cardiovascular support. The recipient, increasing age, preoperative support, surgery and drugs including amiodarone. And procedural, these include long ischemic times, long cardiopulmonary bypass times and size mismatch. Diagnosis, so we'll first talk about primary graft dysfunction of the LV, classified as mild, moderate, severe, based on vasoactive agents, echocardiography, pulmonary artery catheter, and also ECMO VAD support. While the RV, primary graft dysfunction, has no severity scale and is based on the pulmonary artery catheter and short-term VAD. Management is supportive of the LV, RV or both, with vasoactive agents and also escalation to mechanical support. Plasmapheresis has also been indicated. So how do we prevent primary graft dysfunction? So far, evidence suggests a single administration of a cold flux preservation fluid remains the gold standard for myocardial prevention, but also the use of leukocyte depletion filters has been suggested. However, the problem remains you can't manage and prevent a complex problem with a single treatment. Currently, research is ongoing to identify patients who are at risk of primary graft dysfunction. A range of biomarkers have been elucidated. These include TNF-alpha, interleukin-6 and procalcitonin.